Jenny, and I'm from Wiltshire. I work in public health.
Thank you.
My question is for Mark, with regards to the last study he was talking about. Did you look at how the hand dryers are cleaned as well, especially the ones where you're putting your hands in, if you're looking at the splatter coming out as well?
Thank you for the question. Yes, and so the international study where we did work in France, Italy and the UK, some of the data I think I showed you, but it is in the paper, was from actually sampling the dryers themselves. And that's where we found the excess of MSSA stroke MRSA. So that some of that splattering will go directly onto the air dryer itself. Some of it, of course, if you've tried to use certain air dryers, I'm not going to go at any one in particular here, it's very hard to keep your hands in the middle of two blades without touching the blades. So yes, there is meant to be a maintenance schedule, I understand, or a cleaning schedule associated with the nice stuff that accumulates in the gutter of some air dryers. But judging by what one sees when one sees these in the flesh, that doesn't seem to happen frequently enough.
My question is directed at Mr. Smith. I am a GP in Swansea, and I don't recognise the comment about GPs not admitting patients with cholecystitis and just sending them away with antibiotics. I could be wrong, but I've been a GP 22 years working in and out of hours. Our challenge is we send them in and they are bounced out of hospital on oral antibiotics because of pressures on hospital beds. My question to you is, would it not be, whilst you can have the pathway, our pathway says have a hot op, never happens because of pressures on the system in secondary care, but my question to you would be, would it not be an alternative solution to have, like they have going around critical care units, where you have antimicrobial pharmacists, infection prevention teams accompanying the hot surgical teams or the hot medical teams and actually preventing that discharge until they have the definitive treatment they need? Because all I get is bounced out of hospital, they become more unwell, they bounce back in, they bounce back out, they're then taking up appointments with me to try and expedite the op, and then sadly, as my nana found, she passed away from a completely unrelated sepsis. But if she'd had her first operation, would she have not been bouncing in and out of hospital and being put at risk? So I just wonder if there's a better solution that actually, yes, educate the GPs and anyone else who's admitting in with cholecystitis, but actually at the point of admission, making sure that they get the hot op that they need, rather than what does happen is they bounce them out.
What a fantastic question, and I totally, I can't see you, but I totally support everything you're saying there. I was deliberately being inflammatory regarding the GPs, because what I'm also one of the champions, and this is related to my role within NHS England, is that surgical units should not have any barrier to review and should be able to definitively treat their patients at the point of contact. So wherever that GP is, yes, that you're quite right, you need to refer them in, but the whole point is, if we get you guys on board with the IPC and the surgeons within the trust, explaining to the trust that the whole pathway and the flow, then when you refer a patient in, there shouldn't be any barrier to review. The surgical team should accept them, and then when they're in the hospital, there should be the adequate resource to treat that patient on that index admission. And really, that's what I'm trying to get. You cannot do, the surgeons, joking apart, the surgeons can't do this on their own. IPC can't do this on their own. GPs, we have to come together. This has to be a team approach to change the pathway. The other pressure that's coming is that NHS England, I appreciate you know, there's other people from around the...
Welsh.
I know you are, yeah, and Scotland as well. But the NHS England, for example, are actively advocating that laparoscopic cholecystectomy should not be done, and that we should be just treating them symptomatically and with antibiotics. It goes entirely in the face of all the evidence that we've found identified, and it's just not acceptable. So yes, I totally agree. We should be bringing the patients in easily from the GPs, but then when they're in, we need to sort them out there and then. It's difficult, but we've got to work together to make that work. And genuinely, we are trying to do that. We can't do it without you, and you can't do it without us, if that makes sense.
I agree, it should be a collaborative approach, and I might well come to you for your figures, because money talks in Wales, particularly Swansea, more than anywhere else. I have one more, if I'm going to be cheeky, because I've got the mic now. Being a GP in Swansea, we are the dubious holders of the highest C. diff count across the UK. Aren't we lucky? And that's probably because the surgeon's obviously just handing out all those lovely antibiotics. I digress. I'm joking. What I would like to say, though, is I absolutely loved your phrase, ascertainment bias. And I think that's why we have the highest levels, because we have been actively chasing C. diff diagnoses, which other health boards in Wales and across the UK look for cases very differently. So they're not actively looking for them to address the issues. And we've recently started a whole system, significant event analysis review, involving across secondary care homes, our other community partners, and local authority to try and address the reasons why we have this huge C. diff population compared to everyone else. But the biggest challenge we find is stopping retesting after successful treatment. And that's a huge barrier. So if you've got any tips about how we can change behaviour around testing, that would be enormously helpful for the whole of infection prevention, but particularly C. diff.
Okay, thank you. So very, very briefly, that's why I think that simply comparing rates of, or numbers, crude numbers of cases without the context of how frequently did you look for those cases is misleading, and that's the battle that I'm sort of engaged with at the moment. Regarding the retesting, the data should be deduplicated. So certainly all the data in England, I'd be very confident in Wales and Scotland, should be deduplicated on a 28-day basis. So any repeat positives within 28 days are stripped out, they're not counted again. If you're talking about retesting beyond 28 days, goodness knows why someone is doing that. I'm not condoning the retesting, I share your frustration, but it shouldn't be distorting your numbers if deduplication is working.
Thank you.